Good to be here. As Bob said, I'm Joan Hogan, and I'm welcoming you to the Prairie Doc Radio program. Rick Holm, our Prairie Doc, is in the studio ready to answer your questions of a medical nature. Dr. Holm's specialty is internal medicine. He's a primary care physician with the Avera Medical Group Brookings, and he's also a clinical professor at the University of South Dakota's Sanford School of Medicine. Good morning, Rick.
Good morning, Joan.
Good to have you here. Today we are going to discuss diabetes, and I'm pleased to welcome to the Prairie Doc Radio program Bev Cotton. Bev is no stranger to our program and is always a most welcome guest. She's a registered nurse with the Brookings Health System. I know she works the ER, the emergency room, but she's also the diabetic coordinator for the Brookings Health System. Welcome, Bev.
Thank you.
Nice to have you here.
Thank you.
So you do work the emergency room. If you look at emergency room visits, just across the board, what percentage would you just say off the top of your head or guess, are diabetic related?
Diabetic related?
Yeah, and then it would include a diabetic with foot infection, a diabetic with a heart attack, a diabetic, complications of diabetes.
I'd say it's a pretty large percent, way over 50%. It's surprising how many times we'll see somebody who maybe comes in with some sort of cardiac event or some sort of something related to cardiac or heart, and we do some lab work and lo and behold their blood sugar is quite
20.
Elevated. Yeah.
Or 800.
Yeah.
You two were aware of this. I am shocked. Over 50% of the
definitely,
ER might be diabetic related.
Yep, diabetic
It
related.
just, I obviously know nothing about medicine. That one really blew my mind.
So if you were an insurance company and you were trying to save money, what would you do? You would have 10 Bev Cottons available. You would have diabetic education, you would have compliance monitoring, you would encourage diabetics to take their medicines, you would pay 100% of the medications that's available, even
And
though
diabetic testing supplies.
and provide free diabetic testing supplies if you were an insurance company that had their head on. I mean, that's it. I mean, it makes all the sense in the world to do as good as you can to control diabetes, because that makes a huge difference.
Well, and I think early prevention, I'm seeing a lot more patients when I start doing some of my education where, what we used to call borderline diabetic. I'm starting to see a lot more of those type of patients, which I feel that's where it's all about. When you already having a hemoglobin A1C
That's 9 or 10, above 7, which is the cutoff, right?
and it's been there for years. It's kind of after the fact. So to get somebody in to make them aware, even if they're really not even on medication, but those lifestyle changes, they're huge. And they need to be started early.
So what are the lifestyle changes that would prevent diabetes? I mean,
Well, the two that we always focus on, it's what you eat and what you do. Certainly, the way society is now with all the fast food and convenience food and preservatives in your food, eating a lot more carbohydrate-rich food, the high sugar foods, and then the inactivity with all of the technology. Especially we are seeing it with our kids where they're playing on their phones, they're playing on their computers.
They're not playing outside.
They're not playing outside.
Yeah. Well, if you were not an exerciser, and I know you're a significant exerciser, and if you didn't, really monitor the food that you eat, and I know that you really do monitor the food that you eat, Beth, I just know this, how much would you weigh?
If.
I'm sure I'd be overweight, and part of the reason that I do it is I think I'm about the only one in my family that does not have diabetes at this point in time in my life. So not only do I have a strong cardiac history in my family, I have a strong diabetic history, and so it's inevitable that at some point in time, that I will be practicing exactly, and I do practice what I teach because it's in my family.
So you're doing the preventive measures?
I am doing preventive.
I know you are. You know what? So am I. Although I would say that my diet probably not as good as yours. It's but I live with Joni Holm, the vegetable fruit promoter of the world, and so although I'll sneak in that meat inside and.
Well, I grew up on a dairy farm and I married a beef rancher, so I have to be
Couple
careful
of
what I
strikes
say.
against me right there. You don't want to knock that
We're
in.
not against meat, are we? No, we
Well,
like.
why don't we talk about a good diabetic diet? We need to take a break now, but we'll talk about that when we return.
Okay. Sure. And
Doc Radio, we're happy to have you listening today. And in our studio today, along with Dr. Holm, is Bev Cotton. Bev Cotton is a registered nurse with the Brookings Health System and is also the Brookings Health System Diabetic Coordinator. We're talking about diabetes today. Give us a call if you have any questions concerning this topic, 692-1430. We'd love to hear from you. But before that, we were talking about a good diabetic diet just before we took our break.
right,
Continue on that?
so the new thing, it used to be the diabetic diet, or the diabetic diet would be low calories. And that was it.
Or no sugar.
And
No desserts.
no sugar, no desserts. Now we're realizing what?
We're realizing that carbohydrates are kind of where our focus, because the carbohydrates are what actually are converted into sugar, and that's what's causing the problems. And so I don't know how many times I hear, especially probably a little bit of the older generation, if you want to say that, you know, well, I don't eat
The
desserts
older
anymore.
generation.
I'm getting to be in that category now, but you know, I don't eat desserts, and I don't, you know, have cookies in the house, and I don't have this kind of stuff.
But bread and potatoes.
Yes, or fruit. You know, fruit is a natural sugar, but too much fruit even causes problems. And so it's not that I want to say don't eat any fruit from here going forward, but you do have to be very mindful of what foods are the ones that turn to sugar, any carbohydrate, fruit included, milk included. Some of the healthy foods are still in moderation.
Right. I remember when people would come in and they would say, "Oh, I've got to have sugar out of my diet," and that was their answer. And I said, "No. Actually, it's less fat." And that was the words in the 90s and 80s. And now, if you read the nutritional literature, it's not no carbohydrate diet. It's complex carbohydrate, like you get in fruits and vegetables more. But it's also, you know, avoiding the breads,
Right.
Excessive breads. Make it the 9-grain bread if you're going to do the bread, and not so much bread. And certainly potatoes, a small amount of potatoes, okay. Huge doses of mashed potatoes every day, 2 times a day, 3 times a day. You know, if you're going to eliminate something, certainly eliminate. Probably the worst offender would be high-calorie, deep fat fried French fries. That's probably the worst food there is. And would you agree?
I would agree, you know, and I know that a lot of people too will say, well, my doctor just said don't eat anything that's white, which yes and no. Again, if you're thinking that that's going to be the only way to control your sugar, you're wrong, because a carbohydrate is a carbohydrate, but it is still the way that it's utilized in your body that we're talking about, and that's where we get with the whole grains, the fruits, and that kind of stuff.
There you go. What about yogurt? Bob's asking.
It kind of depends on. If I would go with yogurt, I would go with a light yogurt. Don't go with a fat-free yogurt, because if you're going to go fat-free, you're going to have a lot more carbohydrates because they take the fat out and they add sugar. So you have to be careful. And it's not that you can't have it. My motto is everything is permissible, but is it beneficial? So you can eat it, you can eat anything, but what's it going to do to you in the long run? Is it going to cause your sugars to go up? Is it really worth doing that? So
I had a guy yesterday came in, and his sugars had just recently bumped from 120, which was on the border of a little high, fasting, to 199 fasting. Ooh, he's in trouble. It's now diabetes. I added metformin on his diet, on his medications, unfortunately. Another pill, but I think it's huge. But he's got this big belly, and I said, well, what are you eating? And he said, he was a relatively thin guy, but this pot belly. Well, I'm careful about what I eat. I don't eat the carbohydrates. And she says, he's eating peanut butter. He had scoops of peanut butter at bedtime. He says, yeah, that's my downfall. And really, the total answer is if he added up all the calories that he eats. See, I think this is probably the less carbohydrates, good idea. Cutting back on the total calories in a day is huge. And if you want my best advice, I mean, you may disagree, it is to get a calorie app, counting calorie app. I don't know if you have any preference, and count your calories over a week or maybe even just 3 days. It took me 3 days, and I went, oh my gosh, what am I doing wrong? I'm thinking I'm eating a salad, but I'm eating 500 calories of salad dressing. I mean, this was at Grady Hospital. I did this 3 days. I took a calorie thing and I changed my salad dressing totally. And I didn't have my double Whopper. And I didn't, I just changed what I ate. It was
counting calories did it for you.
And I also want to say something about leafy green vegetables. Very important. Okay, I'm Joan. You're.
Well, we had a caller. One of
Okay.
our listeners had a question and wanted to know about carrots and strawberries. Are carrots and/or strawberries good for a diabetic?
Go ahead.
Well, yes and no. In moderation is the key. Carrots, if you look at the glycemic index, which is kind of another way of looking at how you are utilizing the sugars that you're eating in your body faster or slower, carrots would have a little bit of a higher glycemic index. I believe they have about 6 grams of carbohydrate for a serving. Strawberries the same way. Are they good for a diabetic? In moderation. You can't be eating 3-4 cups of strawberries and or carrots at a sitting without thinking that your blood sugar is going to be elevated.
So explain the glycemic index a little bit because it's very important. Which is more absorbed faster, a molasses or table sugar?
Table sugar. Molasses.
Molasses.
Yeah.
I mean,
Yeah.
but it's funny. I mean, what is worse, white bread or potatoes versus orange juice? White
Orange.
bread.
No. Well, white bread. Yeah. You're right.
You're thinking the opposite
Yeah.
direction. What I'm saying is the faster absorbed
Yes.
is the white
Right.
potatoes and white bread, faster than table sugar. And molasses is supposedly one of these very, very, very fast absorbed things. That's the glycemic index. Explain that.
Well, it's kind of, I don't know how they come up with the glycemic index per se, but it is a way of looking at the higher the glycemic index, the faster that you are going to be turning that basically to sugar. So a lower glycemic index food is going to take longer for your body to digest, to actually turn it to glucose. And so that's kind of one way of looking at it.
For example, milk, is slower to be absorbed because it's got a disaccharide. It takes a while for you to break the disaccharide into a monosaccharide and get it absorbed.
So, that gets to be a little bit complicated for a lot of people, and so I don't always introduce that until, it's probably the last ditch effort to make some improvement on their diet because it's confusing enough already. So back to the question, carrots and strawberries, are they good for a diabetic? I think that, again, the rule of thumb is moderation in your portion sizes is the key. As you and everything, you have to look at a portion size. And then if you're monitoring your blood sugars on a consistent basis, the best way of knowing whether or not what's happening to your blood sugar is to take a blood sugar both before and then about 2 hours after you eat to see how elevated your blood sugars are going to be. And that's kind of your clue as to
how fast you absorb it.
How fast you're going to absorb it, and should I be doing this from here going forward?
Bev, when you say moderation in small portions, I know a lot of people intend to lose weight and they work on it and they really go with small portions, but they're hungry. They're just plain hungry. If you went for small portions for X number of days, the word is stomach shrink, would that happen? Or what do you do for these people who just say, I'd love to, but I'm plain hungry?
Well, usually the reason they're hungry, as far as I'm concerned, is because they're not eating a balanced diet. If you were to eat a balanced diet with all of the food groups involved in the right proportions, your body is going to utilize that. It's just like putting high premium fuel in your car. your car is going to run up much more efficiently using a high grade fuel, and that's
Good food.
exactly what good food does to you. And so you can tell if you are going to have, say for instance for breakfast, cereal and milk for breakfast, you eat it at 7 o'clock, by 9 o'clock you're probably starving. But if you would have something like a whole grain piece of toast with maybe an egg or something like that, something with protein, because we really encourage you to try to add some protein to your meal if possible as well. That is going to take longer for your body to digest, so it stays with you longer, so your satiety is greater.
So
better.
if you just do 3 meals a day and you made sure there was some protein, that would help
Right.
with
Eggs
the hunger.
are the best protein, by the way. So we've all bad-mouthed eggs in the past, but now we're realizing that
Really good.
it's the best balanced protein. I've often said that they've looked at rat studies, and if you gave the same amount of calories one meal a day versus the same amount of calories spread through the day, the rats have less obesity if it's spread through the day. And so if you're spread it out little at a time, you're better off.
Right, and especially with a diabetic, because certainly we want to watch the calorie intake, but you can consume 1,000 calories in one meal and then not have hardly anything the other part of the day. With a diabetic, that's dangerous because you need to have a consistent amount of carbohydrates dispersed throughout the day to maintain a stable blood sugar. And that's why we teach so many carb choices per meal, along with the protein, along with some fat and fiber. That's the balance. The balance with a diabetic means you have to have that consistency of the same amount of carbs per meal if possible. So.
Okay. Well, it's a fascinating subject, and I'm sure many of our listeners are as fascinated as I am by it, but we are due to take a break. We'll be back right after these words.
We're clear.
Us today discussing diabetes. She is the diabetic coordinator with the Brookings Health System and extremely knowledgeable on this topic. We're learning a lot. I'm learning a lot. I really appreciate it.
Let's talk about monitoring blood sugars and low sugars. I've often thought that the lowest, that a person who goes too low burns brain cells. And I think there's some new data to support what we've thought, many of us have thought for a long time. And that the last thing you want is a low sugar because it kicks all your counter-regulatory mechanisms into action, and it takes you 3, 4, 5 days to rebalance the whole system. And so one reaction will drop you so low that you hit this counter-regulatory thing. You measure your sugars later, or write down, and they're high, and you go, oh, I need more insulin, when what you just did was kick it too low, causing the counter-regulatory things to kick in. Explain that a little bit more. The Shmoji Effect.
Well, I think, first of all, I just want to say that I think that when people have a low, they overcorrect all too often, which you're right, then it shoots their blood sugar sky high and they still feel terrible because the symptoms of a low blood sugar are that sweaty, clammy, feeling like maybe I'm going to pass out, maybe a little irritable, maybe your heart is racing a little bit, just basically kind of feel like crap. And you don't want to feel like crap, so you feel like, okay, I have to hurry up and eat something to counteract that, but they overdo it. We use the rule of 15, which is in order to correct a blood sugar, you start with 15 grams of carbohydrate and then wait 15 minutes to see how you feel. Well, 15 grams of carbohydrate would be about 4 ounces of juice. I remember working at the nursing home where we would take 4 or 5 packets of sugar, pour it in the juice, feed it to the resident to make their blood sugar go up, and then...
And that's about 80 grams of sugar.
Right. And then all of a sudden now their blood sugar is 300-400. And so then it's like, well, do you give them insulin? What do you do? So you're right. You're just kind of going back and forth, back and forth. So the first thing is always have something available especially if you tend to have a little bit of that low blood sugar, but have the right amount. The other thing that people don't do is if they have a low blood sugar and they correct it, now they're feeling better, then they just go on their merry way. Well, what's going to happen is eventually they're going to have another low because they don't have anything to stabilize that blood sugar. So they need to have a snack that now includes a little of that protein to stabilize. So maybe a few crackers with a piece of meat or a half a sandwich or something like that, unless they're going to eat a meal. But that will stabilize that blood sugar so they don't go on that roller coaster.
So what happens is a person who is having too many low sugars are driven to eat to counteract this, and they gain weight.
Right.
And then their diabetes is even more out of whack. So the problem, and that's the reason insulin sort of oftentimes causes weight gain, that they're taking too much or it's not balanced correctly. And I really have, that's why I often will include metformin in a diabetic, because it keeps them from overeating. It kind of raises it a bit. It does the right thing about fat in going into the free fatty acids into the lipid cells. And so I'm happy about metformin.
Can I ask you, does the insulin pump make a difference? Does that automatically give you insulin when you need it, or doesn't it work that way?
Well, it will eventually.
Yes. There's a little bit of a misconception with a lot of people that all they have to do is put an insulin pump on and they walk away and they don't have to ever do anything with it. The insulin pump is geared to mimic your pancreas, where it is supplying a little bit of insulin throughout the day as you need it to keep your blood sugar status quo, and then when you are eating a meal, your normal pancreas will secrete some insulin in response to that glucose that is in your blood. Well, that's what you do then with the insulin pump. You need to bolus yourself with an amount of insulin that is in relationship to the food that you're eating. So you still need to be very knowledgeable about what you're doing.
Right. You can do the cheap and dirty insulin pump by doing a combination of a long-acting insulin, which gives you, the insulin pump is giving you a basal amount of insulin continuously through the day and night. Maybe it'll drop to a lower amount during the night, but it'll give you a continuous amount. And then with the insulin pump, you just push it when you're ready to eat a certain amount. Push it twice if you're going to eat a higher meal, less. On the other hand, you can do sliding scale regular or Humalog insulin, fast-acting insulin. So you have a long-acting insulin that gives you maintenance, and then when you have a meal, you give yourself a faster-acting insulin, or you check your sugar and you see it's a little high, give you an extra amount. So you can do a sliding scale, regular or fast-acting insulin with a long-acting basal metabolic rate, which is very similar to an insulin pump. I mean,
right. The only advantage. Well, I shouldn't say the only advantage, but one of the advantages of an insulin pump is it does have an alarm that will alarm you if you're going either high or low, which for some people, if we're trying to avoid a low, it's alarming them before it gets to a point where it's too low so that they can do what they need to do early on.
If they have the continuous monitoring blood sugar thing.
Which most of them are anymore. But
is that right? Tell me about that continuous monitoring blood sugar thing.
I have a couple of what we call a continuous glucose monitor that I actually encourage the doctors to use a little bit more. And what it is it's a little device that will be put on the patient, and then they have to continue to check their blood sugars. But what I get then from that is 7 days worth is usually the norm. 7 days worth of blood sugar results. About every 5 minutes it records, and so I can see if your blood sugar is going up or down, because when you're poking your finger and checking your blood sugar, you have no way of knowing, am I going to still go higher or am I on the downhill side of this? So what I do is I have these patients do a log where they tell me what they eat, tell me what their blood sugar is, tell me how much insulin they give. And then I look at all that information and compare it with the graph that I get.
Which is an every 5 minute monitor, but it doesn't have to stick you every 5 minutes.
It's one sensor, but they just have to monitor their own blood sugars, usually 3 or 4 times a day. And it's really been eye-opening for some of the patients that I put it on because they think they're doing a pretty good job until they see that, wow, my blood sugar went up over 300. My blood sugar's never been 300 when I check it. That's because you're checking it before you eat, and this is what happens after you eat.
And it also tells you if there's too much insulin, because oops, there's a drop I didn't know I had. Oops,
Right.
there's another drop I didn't know I had. Too much insulin, driving me to eat more, and all of the complications thereof.
So
This is called a
helpful.
what?
Continuous blood glucose monitor.
And you can do it for a week and then
Yep.
adjust your insulin accordingly.
Yep. It's a good tool for the physicians to kind of know how am I supposed to adjust the insulin dose for this patient. You know, taking into consideration activity, which activity is going to make an influence on how rapidly you're using up that sugar as well. So all of those little things come into play. So.
Well, just as I said, very fascinating. I still can't get over that figure you came up with at the outset of the program. Over 50% of the people who visit an ER have a diabetic-related problem.
Yes.
On that note, we're taking our final break. We'll be right back. Prairie Doc Radio, I'm Joan Hogan. In the studio with me is Dr. Holm and Bev Cotton. We've had a fascinating discussion about diabetes. We're just about out of time. Dr. Holm?
Well, tomorrow night is the last of our summer shows, reruns, and then the following week is going to be the new season. Tomorrow night is Dr. Crawford, the diabetic expert from Sioux Falls, an endocrinologist, and it's a great show. Crawford is so good. I mean, he's animated and it's interesting, and the information is very worth watching, particularly if you're diabetic, or in particular if you have a family member or a relative or somebody that would benefit from this. Get them to watch that show. Thank you so much for joining us.
Beth, thank you so much for being with us. We hope all of you have enjoyed our Prairie Doc Radio program, and we'll listen again for Prairie Doc, brought to you by the Avera Medical Group Brookings. As always, you can hear more from Dr. Holm online at prairiedoc.org. Thank you for joining us today, and Dr. Holm, thank you.
Thank you, Joan, and thanks so much, Bev and Bob, and stay healthy out there, people.